Well, very good evening, everybody. Today I'm going to present about policy implementation program with respect to our state, that is Uttar Pradesh. As we all know, Uttar Pradesh is a very big state. It is said that the population of Uttar Pradesh is almost equivalent to Brazil. As far as India is concerned, it contains about 16% of the population and 9% of the area. Now, as we all know, health falls in the concurrent list of our constitution. As such, most of the features with respect to planning, planning of health in UP is partly its own. Many of the features are same as those in other states. However, there are few salient features which I am going to discuss today, and these are as follows. Nursing has been considered as the backbone of public health and strengthening of the nursing cadre. As we have already seen in the past few years, especially noticeable in the Sixth Pay Commission, the salaries of nurses has increased to a larger percentage as compared to doctors. Even Government of India has given a lot of importance to nursing, and so has the state of Uttar Pradesh. Effective monitoring and supportive supervision by HMIs and MCTS, that is Mother and Child Tracking System, including scorecard. HMIs, as we know, is a very powerful tool in the hand of top management, whether it be at state or center, to control day-to-day or monthly function of any organization. It has also been recognized that health of the mother and child is of utmost importance. It has been observed that most of the mother, after having done first antenatal checkup, they do not come to the health centers, or they may come for the second or third time they miss later. Or even if a child is born in an institute instead of home delivery, further immunization of the child is not taken care of. So right from first antenatal checkup till complete immunization of child, this mother and child tracking system helps. And the scorecard method has also been used. As we all know, a scorecard is a very good management tool with respect to management of any organization. Now coming to ambulances, all ambulances to be branded as National Ambulance Services and adhere to color, design and logo as communicated by Ministry of Health and Family Welfare. Now, ambulances are a very important component of any health services. It has been recently observed that ambulances at health centers and hospitals are misused by the member of their own organization, by doctors and nurses. Instead of carrying patients, most of the time the ambulance services are busy picking and dropping their doctors and other paramedics. Recently it was in news that in Uttar Pradesh many of the ambulances were used to pick the Samajwadi party workers, and it was a very good article on TV news channel. And when asked by the cameraman, none of the passengers traveling by ambulance services were ready to comment as they knew that it was been done, something wrong was been done, and Samajwadi Party people, they didn't want to get highlighted in such an issue. Now, other feature is mission flexible pool. Healthcare to rural population by having decentralized village health plan and locally known and trained ASHA workers to serve local requirements. Now, since independence, village panchayat need to be free from the clutches of center or the state government. Even Mahatma Gandhi dreamt of Panchayati Raj being free from the clutches of the central and state government. So even village health plan is planned. Village health plan is planned by local panches as per the health needs of the villages. Now, also it has been realized that many of the health workers, they don't get their salaries on time, and ASHA, as we all know, is a very important component of healthcare delivery nowadays. So in order to expedite the process of salary payments, electronic mode of payment has been envisaged, realized, and even the detailed data of base of ASHA has been created and continually updated. Village health-wise name list of ASHA to be uploaded on website with address and cell phone numbers, so that things are very well coordinated. Now, the support under NRHM is intended to supplement and support and not to substitute state expenditure. Now, whatever funds are given in NRHM, they are supposed to upgrade the health system. Already state government is funding from its own corpus, and NRHM is an add-on to it. It need not to be supplement. So the center keeps a very close watch on it. In the democratic India, it has been realized and found many times that center and state relations are always under strain with respect to money that is being given by central government to the state. So keeping that in mind, the center keeps a very close watch. All the support for HR will be to the extent of positions engaged over and above the regular positions. So whatever doctors and nurses and other staffs that are employed in NRHM, and they are over and above the expenditure that is being done by the state in its health department. Now, furnishing of utilization certificates is must. As I told you, that central and state relations are always at strain with respect to money. So the state government has to furnish a utilization certificate with respect to money to the center in order to get more funds. Unspent balance with the state is taken under consideration before release is made. The state shall also intimate the interest amount earned on unspent balance. This amount can be spent against approved activities. Now, at times it happens that state is not able to utilize the funds, or they are not able to produce the utilization certificates because of its own documentation problems. So even if the interest is earned on the unspent amount, that is also to be spent on against approved activities only. Now this is the state of Uttar Pradesh. As we see, Uttar Pradesh, as we all know from our own PSM books, one popular term is BIMARU, that is Bihar, Madhya Pradesh, Rajasthan and Uttar Pradesh. And Uttar Pradesh is one among the BIMARU states. Here the health indicators are at a very dismal state. So if you see the maternal mortality rate, All India figures are 212, but when it comes to UP, the maternal mortality rate is very high, that is 359. And in fact, let's come to infant mortality rate, which is one of the important indicators. All India rate is 55, sorry, all India rate is 44, whereas in UP it is 57. So here also one important indicator, that is infant mortality rate, is at a dismal position. Now coming to total fertility rate, the population of UP men, see the total fertility rate, that is 3.4, whereas all India it is 2.4. So this is the reason it is called one among the BIMARU states. The population of UP is as good as one of the countries, that is Brazil in South America. Now let's come to the NRHM program, and it is like gradually the indicators need to be improved. Some state targets have been set for the year 2013-14. The MMR target has been kept at like current it is 359, and for the 2013-14 it has been kept at 218, then subsequently 198, and later on, as the 12th plan finishes, it need to be 163. So compounded annual has to be minus 9.4. So gradually indicators need to improve and maternal mortality rate should go down. And similarly IMR 58 followed by 52, then at the end of 12th plan it need to be 41, and with CAD at 10.9. Similarly fertility rate present all India is 2.4, but UP is 3.4, and it has been planned that it need to come down to 3.22, then 3.14, and by the end of 12th plan it need to be 2.98. So compounded annually it should go down by 2.64 every year. Now coming to the key conditionalities and incentives. So, mandatory disclosure. The state must ensure mandatory disclosure on the state NRHM website of the following and act on the information. Now the provision of website has been made compulsory. As we all know, media is very active, so in order to maintain transparency and good center and state relations, a public disclosure on the website is a very important tool. Like we all know, RTI, there is something called right to information. So if an information is disclosed right at the website, so I feel the number of RTIs might go down, and it's a very good tool at the hand of management, as I discussed earlier. Now coming to the point, facility-wise deployment of all HR including contractual staff engaged under NRHM with name and designation. Now name and designation has been very important, so that if at any time any transfer has been done, so immediately authorities will come to know. Now in respect to deployment, now as you all know, as and when the politicians are not happy, they keep transferring the high profile people. So as we all know, the recent Durga Shakti case, moment politicians are not happy, they transfer the IS officers. So when it comes to chief medical officer or the medical officers, they stand nowhere as compared to IS officers. Now patient transport ambulances and emergency response ambulances. Total number of vehicles, types of vehicles, registration number of vehicles, service delivery data including client served and kilometer logged on monthly basis. Now, as you all know, ambulances are many times misused. So, the total number of vehicles must be declared in the website, including the registration number of vehicles, service delivery data including client served. So, they need to be transparency. So, if anybody wants to check whether the right client has been served, it can be checked, and the kilometer logged on monthly basis, so that we can know the performance of the ambulance services. Now again, incentives will draw additional allocation based on following performances. Now the incentives will be given on the basis of transparency, accountability, quality assurance, intersectoral convergence, recording of vital events, and creation of public health cadre. Now health cadre, just on the basis, like on the lines of IAS, has been envisaged and dreamt by many of our visionaries before also. So again, towing the same line, we are still dreaming about that. Policy and systems to provide free generic medicines to all public health facilities. Medicines, as we know, are very costly. Generic medicines are still cheaper, and when the government buys generic medicines on large, it becomes even cheaper. So many times it has been seen that whenever a patient gets discharged, if a patient's bill is ₹100, the bill of medicine itself comes to around 40-50. So roughly about 30 to 40% say the cost of bill is because of medicines. So medicine need to be cheaper if health services are to be utilized by public at optimum rate. Coming again to the point, Clinical Establishment Act 2010 as per their requirement to regulate the quality and cost of healthcare in different public and private health facilities in the state. Now, it has been realized that India cannot survive without private health sector. Maybe whether it's health or oil and gas, or whether it is FMCG, even railways need to be privatized to a larger extent. Now coming back to the health, already health sector, as far as outpatients are concerned, 70% of the health in India is served by private practitioners. But when it comes to indoor patients, still a larger chunk of patients are served by hospitals which are in public sector, which is rate around 55 to 60%. Now the private health sector is gradually coming up in India, and even in UP many good private hospitals are coming up, I have heard. So the government dreams that if Clinical Establishment Act is made more vibrant in any state, the health scene will change. Coming to the next slide, that is management strengthening. Now full-time mission director for NRHM and if other full-time director, joint director, deputy director, finance not director finance, not holding any additional responsibility outside the health department. Now a full-time person is very important, who is fully dedicated to the health. So it's need not that one person is posted director and within few months is transferred to other department or other seat or any other city. So stability of tenure, as we know by Henry Froelich, who is the father of management, he said stability of tenure is very important when it comes to good management. Now fully staffed program management, support units at state, district and block level. Now whether it's PSC, CSC or hospital, any hospital need to be fully staffed if optimum output is the mind of the top management. Selection of staff to key positions such as head of health at the district and block level and facility in charge to be based on performance and stability of tenure. Again, stability of tenure, as I said, is very important if hospital is to be properly managed. And also the staff need to be promoted, or if the staff is on contractual basis, His further extension is to be given on the basis of performance and not because he has got a letter from some politician or other way around. So right people need to be promoted and right people need to be given extension as far as the job is concerned. Now, public health planning and financing. Now, mapping of facilities, differential planning for districts with poor health indicators, but resources not to be spread too thin, or it need not to be a targeted investment. Now, districts which are poor in health must be kept in focus. More resources should be diverted to those districts which are having poor health indicators. But even keeping that in mind, there should not be a disparity with respect to health resources. So the resources need not to be spread too thin, or they need not be in targeted investment. So even if any district is very poor in health indicators, so it should not be the whole of the resources are diverted to that district and urban areas or other districts are neglected. So the progress with respect to health indicators should be synchronized. Everybody should work together. All the districts should improve in the positive direction. Now coming to HR policies. Minimizing regular vacancies, expeditious recruitment, example taking recruitment of medical officers out of public service commission's purview, merit-based and transparent selection, recruitment rules to be aligned to the needs of health, human resource, progression and professional development, rational and equitable deployment, stability of tenure, suitable performance measurements mechanisms. Now again, regular vacancies, as we know, has been discouraged. Government is no more interested in full-time employees. Just like private sector, contractual staff has been employed, and the recruitment need to be expeditious. Generally, recruitment done from public service commission takes a lot of time. No, again, even if the staff is recruited on basis of contractual basis, merit is very important, and the recruitment rules to be aligned to the need of the human human resource. So whatever is required must be recruited. Sometimes in government sector, at some department the staff is surplus, and in other districts, just because that primary health center or sub center or CSC is in inaccessible area or in a hilly terrain, people after approaching politicians get their transfers to the city areas. So generally seen, village and village, tribal areas, hilly regions are neglected. That should not be the case. So most of the time the staff is surplus in important cities or good towns, whereas in hilly areas the seats are lying vacant. There is no doctor at all. This should need right equitable deployment, stability of tenure, as we discussed, is very important. Then performance measurement mechanism. They need to be scorecards, regular performance appraisals. Now HR accountability. HR accountability is a very powerful management tool. Facility based monitoring, incentives based on functioning, performance appraisal against benchmarks, incentives for difficult areas. So there must be facility based monitoring, incentive based on PSC, incentive based on functioning. So those PSC, CSC or sub centers who are functioning well or they have been managed well, so those need to be encouraged, and suitable appreciation in the form of incentives is given to that. Performance appraisal against benchmarks. So the targets are set, and if those achieved, by the staff. The staff is given further extension or appreciated in some other form. Incentive for difficult areas. Now coming to the incentives, recently I've heard, I don't know, I think it's about Himachal Pradesh. It was in the paper that National Health Mission has published in paper that they are willing to give doctors even 1 lakh rupees per month if they go to hilly areas or difficult terrain, and 1 lakh to the postgraduate doctor who is freshly passed, and even MBBS doctors they are giving 70,000-80,000 per month. Now coming back to ambulance services and referral transport, universal availability of GPS fitted ambulances, reliable assured free transport for pregnant women and newborn, clear policy articulation of entitlements. So GPS is fitted in order to avoid misuse of ambulance and to track their positions so that they can be optimally used. No doubt the ambulance services need to be reliable, pregnant women need to be given importance if we have to improve the MMR and IMR. Now, establishing integrated call centers for timely response and effective services. Now, call centers to have a better coordination. Now, coming back again to the, now these are the family planning projections and conditionality. Goal indicators have been set. Now, total fertility rate, current status is 3.4. 13-14 it should come down to 3.2. Then 14-15, just a minute. So I will tell probably. Total fertility rate present, current status of UP is 3.4, and by 13-14 it should decrease to 3.2, then 3 in 14-15, 2.9 and then 2.7, and this is total fertility rate. 3.4 is present, then 3.2, then 3, then 2.9, then 2.7. And respect to no. Okay. Now again coming to the goals. Now the roadmap for priority action. Emphasis on postpartum family planning services, strengthening of postpartum ICD. Now, as you all know, once a mother delivers a child, at that time it is very easy to motivate a mother. So it has been seen that if a mother is motivated at the time of delivery, she will very easily accept the family planning measure. So strengthening of postpartum ICD has been envisaged. Now, again coming to the center-state government communication. Center-state government communication for strict compliance. So the center has asked state government that in order to utilize the fund optimally, following need to be kept in mind. It has been observed that contractual HR engaged under NRHM, that is specialist doctors, both MBBS and IUs, staff, nurses and ANM are not posted to the desired extent in inaccessible and hard to reach areas, thereby defeating the very purpose of the mission to take services to the remotest part of the country, particularly the unserved and underserved areas. It must therefore be ensured that the remotest sub-centers and places are staffed first. Contextual HR must not be deployed in better served areas until the remotest areas are adequately staffed. No sub-centers in remote, difficult areas should be without a doctor. Further, CHCs in remote areas must get contextual HR ahead of the district hospital. Compliance with these conditionalities will be closely monitored and salaries for contextual HR disallowed in case of violation. So it has been seen most of the time that government staff, whether they are doctor or anybody, after greasing the palms of the politicians or those in higher authorities, get their transfers in good cities and towns. So this has been observed many times, and NRHM and central government and state government, they are very particular that doctors should be available in unserved and underserved areas. Priority has been given to those areas. So friends, that's the end of the presentation. So that was presentation on Uttar Pradesh, which is one among the largest state of our country with respect to health. Thank you.